Hi, everyone. Welcome and thank you for joining Rare New England's Medical Genetics Career Fairs. My name is Nicole White, and I'm the Executive Director of Rare New England. I wanted to thank all of our sponsors for making this event happen. Thank you to New England Regional Genetics Network for supporting our career fair, as well as our platinum level sponsors, Takeda and Vertex, and our gold level sponsors, Ultragenyx and Horizon. I'll pass it on to our moderator, Dr. Corson.
Good evening. So my specialty is pediatrics with a focus on genetics as a subspecialty, but specifically the area of biochemical or metabolic genetics. So if you think back on your biochemistry, I deal with patients and families who have defects in those biochemical pathways. Biochemistry can be abstract and rather dry, but it is that patient contact that really puts the human back in biochemistry and shows how relevant the urea cycle or the electron transport chain really is. So why are we doing this program tonight? Well, genetics impacts almost every area of medicine. So as you can imagine, there's a growing need for geneticists in this country and abroad. Patients and families want and need to hear information about the diseases they have, information to plan their futures, information as a couple with a family history looking to have children, and information about effective therapies now available for genetic diseases. And considering that there are more than 7,000 rare diseases, not all genetic and growing, that's a lot of information that needs to be shared. But the impact of genetics is not just in rare diseases. Genetics impacts how we manifest lots of mainstream diseases like COVID, how we respond to disease, how we utilize and break down medications, what medications are available or effective or safe, and so on. So this evening, you will hear from 3 physicians who specialize in the area of genetics: a clinical geneticist, tonight, Dr. Katie Anderson, a biochemical geneticist, tonight, Dr. Amy Kritzer, and a research geneticist, tonight, Dr. Hilary Scott. You'll hear a bit about what they're doing, how their genetics expertise has helped them, how it has helped to treat their patients and families, and how the experience has impacted their own lives. A Q&A session will follow the 3 presentations. If you have questions, and we encourage you to ask them, please put them in the Q&A box, not in the chat area. And after we have the Q&A session, I will guide you through some additional opportunities to learn more about genetics. Okay, on to our first speaker. I want to introduce Dr. Katie Anderson from the University of Vermont Medical Center, Burlington, Vermont. Dr. Anderson is a medical geneticist at the University of Vermont Medical Center and assistant professor at the Larner College of Medicine at the university. Her clinical interests include inborn errors of metabolism, pediatric genetics, and prenatal genetic counseling. Her research interests are focused on whole genome sequencing in acute unexplained illness. She performs a variety of specialized procedures, including skin biopsies. Dr. Anderson enjoys connecting with her patients and their families to complete the diagnostic odyssey and to develop a strategy that best supports the patient in growth, development, and health. Genetics is a confusing and ever-changing specialty, and she relishes the opportunity to learn with and from every patient. For more information about Dr. Anderson, please see her bio on the RNE website. Katie, thank you for joining us this evening.
Hi, thank you so much for inviting me to join this conversation. I am, of course, going first, and I have never done this before, so you'll get my version of this. I am a medical geneticist in Vermont, as Dr. Corson said. I came to genetics as a specialty after first training in pediatrics. I think that's one of the things that I wish more physicians knew, that medical genetics is its own specialty. It's not a subspecialty necessarily of pediatrics. So I can take care of patients from preconception to postmortem and everything in between. So I'm not just a pediatric geneticist. I also see adults and prenatal visits and help people sometimes even after unexplained deaths in families. I got to genetics after going through my pediatrics residency and sort of realizing that the kids that I kept following, or the ones whose stories I wanted to know the end result to, were all the ones that we had sent genetic testing on, or we suspected a genetic condition, or also inborn errors of metabolism. That's something that I'm really interested in, but you'll hear more about that from Amy Kritzer. Although, to say the least, changing the narrative and the learning process in biochemistry from just abstract pathways and circles and cycles to making it clinically relevant is a huge difference, and makes, for me, biochemistry so much more exciting. Part of my job is seeing patients for all different kinds of reasons. Some of them can be individuals who have learning differences or developmental delays. Others may have facial features that seem a little bit different from their family members, and trying to figure out if there's something bigger going on that might provide a genetic explanation. And I guess I just generally feel pretty lucky to be in genetics at this particular time. I would categorize some of my predecessors as much more talented in identifying particular syndromes with facial features, but I have the luck of having great genetic testing options so that I can find answers for patients that maybe have eluded them for decades. I have 2 young men that I follow who had a lot of genetic evaluation as children, and they're now both in their 30s. And now, just recently, for the first time ever, we had a genetic explanation for why their lives have been so different. And that's been a really interesting journey for them. And that's the sort of journey that I really enjoy. I like putting the pieces of a puzzle together and figuring out the answer. And when there's an opportunity, I really enjoy the opportunity to treat patients and sort of fix the underlying problems. So another piece that I'm very involved in is newborn screening. So I will see patients who've had differences on their newborn screen that might indicate they have a condition that we can treat. And so we start that process really soon after birth, which can be a really rewarding thing as well. In terms of my day-to-day life, I see patients in clinic, mostly outpatient, and I work closely with a genetic counselor who not only helps me get all the information and the records for individual patients, but also helps me order genetic testing and keep things organized. We work closely together and typically see patients together. I get the luxury of an hour with each of my patients, so I get to get a deep sense of what's going on, what their questions are, where their challenges are, which I really appreciate. And then I also see patients in the hospital if they come in and there's a question of something genetically different, or perhaps their lab studies don't follow what the typical pattern might be for their disease illness. And so we look for genetic explanations that might help better understand what's going on, as well as potentially doing treatments to help them in that setting. I live in the great state of Vermont. It's beautiful and lovely, but pretty rural. So a lot of my patients travel a great distance. And so I really appreciate the fact that it's hard for a lot of them to come see me and my team. We do a fair amount of telemedicine, particularly for adult patients who are really just looking for genetic testing and may not have something that we can physically see different on the outside. But otherwise, a lot of these visits are really important to do in person, because I need to look at someone and be able to sometimes measure their hands. I look at everybody's hands, and I tell my patients all the time that someday I'm going to learn to be a palm reader, because I'm looking at their palms and how the creases in their hands, the patterns of that. And so it's overall a really interesting job, and I really just love the opportunity to sort of figure out what's going on for people. And because there are so many genetic conditions, it's pretty rare that I actually see the same thing, like same diagnosis multiple times, even in a month. So that's really kind of fascinating. I get to learn with every single patient, which is a luxury in medicine. A lot of times what we do over and over again. And this is pretty different in that respect. Every day is a learning experience. And overall, I really just love my job. And I'll be happy to answer questions when we get to the Q&A section.
Well, that's definitely a testimonial to genetics as a career. If someone can say that. Thank you so much, Katie, for sharing that. Our next speaker is Dr. Amy Kritzer from Children's Hospital in Boston. Dr. Kritzer is an attending physician in the Division of Genetics and Genomics at Boston Children's Hospital. She graduated from the Albert Einstein College of Medicine in the Bronx, New York. She did her pediatrics residency at the Floating Hospital, Tufts Medical Center in Boston, and then completed fellowships in clinical genetics and medical biochemical genetics at Children's Hospital. Her clinical work is focused on the care of children and adults with rare metabolic diseases and focuses especially on psychosocial needs of patients with rare diseases to improve their quality of life. As physician lead for quality improvement in the division, she creates and implements patient care initiatives designed to improve patient safety and the patient and family experience. She serves as the principal investigator for several lysosomal storage disease registries and is co-director of the Lysosomal Storage Disease Program at Children's. For more information about Dr. Kritzer, please see her bio on the RNE website. Amy, thank you for joining us this evening.
Thank you guys so much for having me. Similar to Dr. Anderson, I think, I came into this field a little bit late. I was actually a pediatric resident when I really decided to go into this field, and I was fortunate enough to have some amazing mentorship that exposed me to what care of patients with rare metabolic diseases could be and what it looked like. And for me, part of why I was drawn to this field was because I liked the longitudinal aspect of care. I liked the idea that I could take someone from diagnosis through therapy and on to their future. And given the extensive nature and diversity in the field of inborn errors of metabolism, it was a really nice balance for me of conditions where there were excellent therapies and kids were dreaming big and living amazing lives, and we just had to support them through crisis. And conditions in which there were not good therapies and we really had to think outside of the box. And that kind of opportunity to really work with families to do better was one of the things that really motivated me in this field. I enjoy the families the most of anything that I do. I, often will talk to families and they'll call me with all kinds of questions and concerns. And certainly during the COVID pandemic, we saw a huge increase in that. And as people tried to determine what their risks were and what was safe and not safe. And we worked, with them to give them the best information we could. I think it's been really fascinating to see the evolution of care from in-person clinics to telemed and kind of now a hybrid system, which has really opened opportunities for patients. For me, working with families and often speaking with them about, what they need in that moment, developing care plans that work for them, that may be not perfect, but are actually realistic, is really important to me. In my role, I've always said I'm not a researcher. I'm not a bench scientist. I'm married to one, but not one myself. But my role has really been to take patient care and in my work with quality improvement to try to figure out how we do what we do, but do it better and do it in a more standardized approach that is reproducible and leads to less variation and hopefully better outcomes. So that's been a really fascinating part of my work that I've expanded over the last couple of years. I personally really love working with students at all levels of training as they explore what this career could mean for them. And I think one of the amazing things about genetics is that there are so many ways to do this, depending on what your personal interest is. And I love to go to meetings where I get to meet people who do something very, very different from what I do. but are equally passionate about it. And I think it's really amazing to be in a field where a career in clinical genetics doesn't look the same for every single person. And it really gets to be what you want it to be. And that's something that I've just come to appreciate more and more over the years. A lot of my focus is working with families, particularly young children who are diagnosed through newborn screening or through kind of early clinical decompensation, to develop plans that get them back to school, back to life, and developing to their potential. And that's really the work that really feeds me. And when we're fortunate and we followed families for many, many years, we also get to then sometimes see them into the next generation. And that's also been work that I've enjoyed. Is in metabolism, we often get to keep our patients for a really long time because there's not a lot of adult medicine providers to send them to. So while I am a pediatrician by training, some of my favorite patients are in their 60s and 70s, and getting to kind of navigate the world with them, which is often complicated, and medical knowledge of those disorders is really limited, has also been incredibly rewarding. And I am very open to any questions about why I chose this field and what I find to be the most rewarding about it. And so I think sometimes the best parts of these conversations come from those questions. So I will defer to other people to chat as well.
Thank you, Amy, for sharing with us. Our third speaker is Dr. Hilary Scott from Massachusetts Eye and Ear Infirmary in Boston. Dr. Scott received her PhD in genetics from Texas A&M University, studying the role of post-translational modifications in neural development and physiology. In 2018, she joined the Ocular Genomics Institute at Mass Eye and Ear and the Department of Ophthalmology at Harvard Medical School for her postdoctoral training. Her focus, the genetic causality of inherited retinal degeneration. She continues to be interested in the impact of genetic variation in inherited retinal disorder patients that is missed by current genomics techniques. Her current work focuses on developing methods to validate potential disease-causing variants uncovered by whole genome sequencing. Since the start of 2022, Dr. Scott has been the Associate Director of Genomics at the Institute. The Genomics Core provides resources to help support the researchers at Mass Eye and Ear that work to understand the causes of vision loss and develop site-saved treatments through their translational research. Hilary, thank you for joining us.
Thank you so much for inviting me. And I'm just going to share my screen. Okay, hopefully you can see the PowerPoint. Are you able to see the PowerPoint?
Not yet. Yes. There you go.
So I have a little bit of a different background. I am actually a PhD, so I don't actually see patients, but I do work in the diagnostic lab at Mass Eye and Ear. And so the diagnostic tests that both of them order actually come into the core lab. And I think that one of the most interesting things for me is that I just get to see the impact across all of the different doctors that see their patients. So I just wanted to give a little bit of background about what we do at Mass Eye and Ear and provide a little bit more detail about the diagnostic side or the genomics side. So as was mentioned, I am the Associate Director of the Genomics Core, and all of the diagnostic tests that the physicians order could be run through our lab. And so at Mass Eye and Ear, we have what's the retinal service. And so our mission statement of the core is to just support the physicians and the researchers by providing the high quality genomic data that drives their translational research. And so we do this through Sanger sequencing. some of the tests we order, Sanger sequencing. And so at the top, you see the little chromatogram. That's essentially when you're just sequencing a single piece of DNA in a single region of the DNA. And then more often we have next generation sequencing. So we have targeted exome sequencing that looks at a specific set of genes that may be a set of disease genes. We also have whole exome sequencing that just sequences the coding regions or the exons. And then we have whole genome sequencing that includes all of the exons, all of the regulatory regions, and all of the introns. So those are some different genetics tests that we can use, not only in research, but in diagnosing patients. And specifically at Mass Eye and Ear, we see in the focus of my research is inherited retinal degenerations. And it's a group of monogenic disorders that cause vision loss in working adults in 1 in 3,000 people worldwide. And so the goal of the Ocular Genomics Institute is to understand the basis of that disease or the group of diseases, and then provide gene augmentation therapies where available. And so I have just a picture of a normal retina, and then one that has rod cone degeneration or retinitis pigmentosa, which is the most common IRD. And then the Venn diagram I have is just all of the genes. There are a little bit over 270 genes that can cause these phenotypes. And each of the circles represents essentially a specific disorder that shares phenotypes. So you can see that there's lots of overlap between the genes and the phenotypes. And so it's very difficult for physicians in clinic to be able to say specifically based on their phenotype what their molecular diagnosis could be. And that's really important because for any of these gene therapies, we need to have the molecular diagnosis. For example, we have a physician that performed one of the first gene therapy treatments for a gene that's called RPE65 for retinitis pigmentosa in an 11-year-old boy. And before the insurance company would allow or approve the treatment, they had to be sure that those were pathogenic variants in that specific gene before he could go through with that surgery. And happy to report that we were able to confirm those pathogenic variants and that he was able to receive that surgery. And as seen, it stopped the progression of the disease and actually has some improvement in his vision. So I just wanted to talk about 2 examples. We had 2 families. So the first family was actually presenting with autosomal recessive, which essentially means that each parent, although they're unaffected, must carry an allele with a pathogenic variant. And so it appeared as though it was an autosomal recessive pedigree. There were 2 candidate genes, and we performed the validation, which essentially means that we went to the bench and performed experiments to try and prove that these were the genes that were actually causing the disease. And we came up with nothing, and we couldn't diagnose the patients. And so we actually reanalyzed and found out that it was caused by a known IRD gene. And what was happening is that in some cases, it can be a dominant pedigree, which means the allele only has to come from one parent, but that this was called haploinsufficiency. So essentially, it matters not just the variant that you have, but that the other allele coming from the other parent can have a dosage effect. And so that was what was shown here, and we were able to solve the patient. And now in the second family, this is an unknown family, and we've performed all of the different kinds of sequencing tests that you can have, all of the ones that I mentioned in that first slide, as well as some other new techniques that can look at long reading sequencing. And so in the first family, we were able to diagnose them because technologies had improved and we could reanalyze. But in this case, sometimes it just happens that no matter what the techniques you use, essentially they're just waiting for that next novel method in order to diagnose their disease. So that's why it's so important to have genetic researchers and physicians that are able to push the field further so that we can have families that can have that answer. Whether they are able to be enrolled in some gene therapy treatment, or whether it just helps with family planning. And in some cases, the families just really want an answer for why they have the disease that they have. So that's been my experience so far. And it's been a very rewarding one. And if you have any questions like the others, please just let me know. Thank you.
Thanks, Hillary. That's great. Actually, one question I have for you, and speakers, you can all turn on your video. Hillary, one question I have for you, how often, I mean, you described some fascinating cases. Is this the way of the future, that that clinicians are going to approach you directly to solve unanswered questions?
So we actually at Mount Sinai, we have a large cohort of unsolved patients.
Mhm.
And so what happens is when a doctor sees a patient, they'll go through kind of the standard genetic testing. And then if that doesn't provide a solution, then the patient can, and their families can elect to go through the research route. And then once they elect to go through the research testing, then we can try all these different methods to try and provide an answer for them.
Wow.
And
Excellent.
actually, it turns out that almost 40% of the patients remain unsolved, and they do kind of feed into and many of them do elect to go through research.
Wow. Okay, so I've gotten a number of you submitted questions ahead of time, so I'm going to pose them now, and feel free to write questions in the Q&A box. So I guess first question that's in the box is, I am currently doing my PhD in genetics, but I work in cattle. So I would love to work with humans, but I'm unsure if jumping between species like this is an option so far into my education. What are the steps I could take to make me more employable in the medical field with my agricultural background? Does anyone have any ideas?
My PhD was in Drosophila, so at least you're in mammals. That's pretty great.
Well, yes, that is. Consider yourself lucky.
Yep.
I do think there's a role for, a change between PhD and postdoc sometimes. And again, this comes not from my direct experience, but from, being married to a researcher who has evolved through his training. But I think that's the goal, is often to expand your knowledge base. So part of it is finding people who are doing what you love, what you want to do, and talking to them. A lot of people, if you say to them, I'm really intrigued by what you're doing, can I meet with you? Can I have a quick conversation to learn about your path? Often people love to talk about themselves, and so often are much more approachable than you think they might be. And I think as a PhD, you are at one level of training, and postdoc is often a wonderful opportunity to take what you know and then acquire new skills. So I think that there should be ample opportunities to think about how you expand from there.
Okay. Katie, talking about that, let's back up. What is the path to becoming a medical geneticist look like? Like, what is the education and training?
So there are a few different ways to go about it. A medical geneticist or a clinical geneticist goes to medical school. So undergraduate, however long that takes you, then medical school for 4 years. And then after medical school, there are several different paths you can take. One, you can do any residency whatsoever. A lot of people go from pediatrics, but other specialties are very welcome and very needed. There's also the option to do something called a combined residency, and some of them are in pediatrics and genetics, which takes place over 4 years. A pediatrics rotation alone is over 3 years. Or internal medicine and genetics, which is 4 years, or OB in genetics, which is 5 years. Someone will have to correct me if I'm wrong on that. There's also another path, which is a little less often taken because it's got a little bit of risk in it, which is to do a preliminary year, so an intern year in any specialty, so a first year of residency after medical school, and then apply in the medical genetics residencies. And so those are 2 years. So my pediatrics residency was 3 years, and then my medical genetics residency was 2 years in addition, for a total of 5. Then there are the laboratory specialties, which are a whole nother kettle of fish.
Okay, thank you. Amy, how are your patient encounters different from the encounters patients have with their other clinicians?
So I often say that we are kind of often the medical home or the cheerleaders of the team. So a lot of what I do is care coordination and really thinking about the child or the adult as a whole human. So often I'll say to families, like, you go to neurology who treats seizures, or you go to nephrology who treats kidney disease. And my job is to think about you as a whole person. And so one of the things I often do with complex patients is really go through, okay, when's the last time you saw your cardiologist? What do you do for how do we make sure you're getting all the care that you need? And I enjoy that kind of multi-system approach to things. I think that, part of my job as a cheerleader or team captain is often to do also the other pieces of navigating with the schools, with dietitians, with social workers, and kind of the other members that support the families from a kind of social and psychosocial role as well.
So with that in mind, what do you do, and what does the primary care physician do?
Yeah, it can be blurry. Sometimes, we joke that that we do a lot of primary care outside of like well child checks and vaccinations. So a lot of times we are the first call for our complex metabolic patients. So if they're vomiting, they may call us to say, what do I do, rather than primary care. So it really depends on the disorder. We do not do vaccines. We do not do kind of, your routine school physicals. But we often do a lot of that primary care aspect of kind of how are you living how is life going? How are things, how are you navigating school and social worlds? And often, families do turn to us first, and sometimes we have to kind of help them navigate what is a call to primary care, what is a call to metabolic, especially for kids where every illness has the potential to land them in the hospital. We often are going to be their first call to make that triage decision about what's the right environment for them.
Mm-hmm. Okay. Hillary, question from one of the attendees. So I got my medical degree in India, and I'm a postdoctoral fellow in molecular genetics and genomics. So I wanted to know, how can I evaluate career options and research in rare diseases, especially in the area of therapeutics? Can you offer some ideas?
Well, I think having your postdoc in what you're focusing on is a good start. And then I think it just depends on what your next steps are in terms of where you want to be. So if you want to stay in the realm of purely research, then your first postdoc, maybe a second postdoc in labs where you really enjoy the work, because your postdoc is where you're really specializing. Again, your graduate studies, you're just learning the basics of what you want to learn. In your case, in the medical field, that's really wonderful, because you have a background that most PhDs aren't going to have in terms of clinical care. If you want to focus on more of the diagnostic and genetic testing, then I would definitely suggest doing a genetics and genomics fellowship, where they have laboratory genetics and genomics fellowships, or something, as Dr. Anderson mentioned, where you go through the American Board of Medical Genetics and Genomics, to where you can get that certification, where you're focusing on that. If you want to stay purely in research, I think you're doing the right things by having postdocs in your specific interest area.
Okay, cool. Thank you. Katie, genetics seems to grow much faster as a field compared to other medical fields. how do you personally stay up to date with developments? How do you collaborate with colleagues on cases?
It does change very quickly. It changes every single day. Part of the way I keep up is just with my patients. Each one has a different diagnosis. And so I am forced, or I get to read about each individual patient. And when I need to collaborate and reach out, it's a small enough and welcoming enough community that it's pretty easy just to send an email, even blindly out into the world saying, help, I have this and I've never seen it before. What can I do? And it's very common for multiple people to respond. If it's to a group or if it's just to one person, I usually get an answer within 24 hours, which is pretty amazing in medicine because they can be all the way around the world and I still get that response.
Okay. Amy, looking broadly, what other professions are relevant to genetics that don't require medical school education aside from genetic counseling?
Yeah, I mean, I think, genetics has gotten so broad that there's lots of ways to touch upon it. So obviously research, not-for-profit organizations where you're supporting the patients with rare disease. There's a lot of opportunity there. There's a lot of opportunity in, allied health fields. So, we are always looking for specialists in physical therapy, occupational therapy, speech and language therapy, social work, that understand what our patients do and are vested in working with our patients. So we have a dedicated dietitians, we have social workers. Those all came through not medical genetics, but through their receptive field and came to specialize in rare disease. And so I think there's a lot of opportunity if you say, this is the patient population I want to work with. There are so many allied health fields. And like I said, social work, nutrition, physical therapy, occupational therapy, school advocacy. I mean, there really are so many ways to support the rare disease patient population.
Okay, thank you. What I'll throw this out to the speakers, think of, was there any particular case that you were involved in that really changed the way you think of medicine, or that really impacted your career? So turning point cases, think about that. But while you're thinking about that, Hillary, can you speak more about how to gain opportunities to do research if you're an undergraduate, especially if you're coming from out of the country?
I think most important, if you want to go into research and you're an undergraduate, then your next step is either going to be an MD, PhD, or a PhD or master's. But it's definitely, that would be the next step. And in order to be a strong candidate for that, find ways to get experience on the bench now. And I mean, they definitely like free labor in academic labs. So it's normally just a matter of, if you have a favorite professor, ask them if you can volunteer in their lab and learn just basic skills. It doesn't have to be something that you're going to focus on in grad school. What they're looking for is just basic skills. And then another thing that could help, in our diagnostic lab, I have a research assistant that just graduated from James Madison University. And before she goes on to medical school, she's spending 2 years learning genetics and genomics. And I have a student intern that started just today. And because of COVID, she couldn't have that opportunity to have any bench experience. So she's going to learn it with us. So whatever you can do to get hands-on experience, read the papers that you like to read in terms of what area you might want to focus on in grad school. Yeah, just find a way to get some bench experience and you'll be heads and shoulders above most of the applicants.
Thank you. Katie, what are opportunities that undergraduates can pursue to gain experience in genetics?
Some that I didn't even realize until my current position is just if you have work study needs, financial aid, we have great work study students who work with our division on a regular basis, and it gets them a lot of exposure. As well as, again, similar to others, just reaching out, people that you're interested in, that are doing something that you're interested in. We always have papers that need to be written, or families or records that need to be tracked down. And so getting involved in interesting cases can be one really great way to connect and get that experience.
All right. Amy, are there are there any difficulties in this field that med students or pre-med students should be aware of, especially if they're going to consider genetics? Is there anything you wish you knew before you went into genetics?
I think one of the challenges we're facing is there are not enough of us and to care for the patient population that exists. And so how do we make sure we continue to provide high level of care when there aren't enough hours in the day? And we're trying to get really creative in how we do that. I think given that I didn't really think about this as a career when I was in medical school, I came to it a little bit later. And so I had the opportunity to really weigh kind of what the different options were, and kind of wasn't finding anything else that I academically was as interested in, or that the patient population just seemed to fit exactly what I was looking for. But I do think that as the rare disease community grows, we need more advocates. We need more people who can, do all aspects of care. And I think that's one of the challenges, is that right now we have physicians, we have dietitians, but we have very few other support roles that are specialized in what we do. And I think that's one of the challenges, is that we want to, as we expand newborn screening, as we expand diagnosis into the adult world, as we recognize diseases present differently as adults and pediatrics, we just need more people who are invested. And so we encourage anybody who is interested in supporting this patient group to consider ways to do that, whether it's through community involvement or medical education or alternative careers. We need you all.
Thank you. Clinical cases that made you go through a paradigm shift or really impacted your career? Any volunteers?
I can share. Sometimes you do work on a case where you feel like I was the right person at the right time for that patient. And, one of them is a patient that she was transferred to our hospital at 3 days of life in an acute crisis. And it happened to be a diagnosis that we had not had at our institution for probably over a decade. But I had cared for a similar patient and really felt that the standard of care was not good enough for this family who had already experienced some loss for other reasons. And we really put our heads together and just thought, what else can we do? And we came up with this whole protocol to feed this baby skimmed breast milk, which had never been done before for her condition, with a compassionate use medication. And she has done remarkably well. And I will always look back at that as the reminder that we have to often think outside the box. And for me, I think I will look back at the end of my career, and that will probably still be the moment that I am most proud of. Because in that moment, we kind of just sat back and said, what else can we do? And I think in rare disease, often there's not a lot of standard of care, or, we're in charge of innovation. And I think that's, to me, have been some of the most rewarding experiences, have just been sitting back and thinking, okay, what else can I do? And there are no kind of crazy ideas in rare disease, because sometimes that out of the box idea is the best thing to come along. And then to see to get to see other people use your idea and have it, be a launching point for other people, I think is something that I have always felt really, really proud of and really happy about.
Oh, very cool. Anyone else want to share?
I have too many for the time, because I think my job's really awesome. I think one of the things that similar to what Dr. Kritzer was talking about, having the opportunity to follow patients for a long time. Sometimes what might seem like the worst thing, giving families very difficult and painful diagnoses for their loved ones, are actually some of the most privileged experiences of my lives. because typically it's families who have been looking for an answer for a very long time or have just had this constant worry. And so the fact that I just have this honor of helping them to understand what's going on with someone that they love, and then joining them on that journey and sort of meeting them where they're at is something that I will always consider to be one of my greatest privileges as a physician. I have other patients that I can think of where we limped them along until they got a liver transplant, and now they're cured and they're totally healthy and normal 6-year-olds. And that's also amazing. But I feel like sometimes the trust and support that both I and the family have in some of those most challenging moments are the greatest honors.
Hillary, do you want to say something?
Well, I'm not a physician, so I don't see patients. So I think that my turning point actually came, I'm adopted, and it was a closed adoption. And I can remember being an undergrad, taking what they called it then neurobiology, now it's neuroscience, and finding all of these different things, Huntington's disease and everything else. They had genetic etiology, and I already had all 4 of my children at that time. And just thinking all of these genetic links, and I don't know my genetic background, and just realizing just how it really does touch on every aspect of our lives when you're family planning. And so I think that's where I decided where I wanted to focus on genetics, and then just seeing the real world implications in the job I have now through the physicians, as I mentioned with the little boy who was able to receive the gene therapy treatment, and then many other families that are looking for their diagnosis.
Wonderful. So in my particular area, like Dr. Gertzer, I was never a bench research type person. So I mostly focused on clinical medicine and teaching. And at some point, I discovered that I'm a pretty good teacher, so I can talk about a case and make it interactive, but I can't teach the way patients can, because I talk about facts and they tell stories, and stories are so much more powerful because they get into your head and they draw on your emotions, and so a big part of my focus in education has been giving voice to patients and having them tell their stories. And it's amazing to watch audiences respond. It's to see 20 people come down to the front of the classroom to ask questions and to connect closely with the speaker. It's quite something. And that's an aspect of teaching and stimulating interest in younger professionals is actually not only a noble pursuit, but it's actually a lot of fun. And so I would put that in there as well.
I will interrupt Dr. Corson to say he did that for me in medical school, and that's why I am where I am right now.
Thank you. All right. Okay, so this is a question that's in that Q&A box, but so the question of imposter syndrome, which is not unique to, I don't think it's not unique to genetics. It's not unique to medicine. It's feeling that, oh my gosh, I am in with all these other people who are so bright and know so much. If they ever knew that I don't know anything, I would be so embarrassed. How do you deal with it? Have you dealt with it, and what do you do about it?
I think
Dealing
it's
with
such
it right now.
Yeah, I think it's such a great question. It really is, because we all deal with it. I think we all have those moments where, even when we've been doing this for, it happens, I think there are a lot of moments where I thought when I was younger, oh, I'm just, new to this, and therefore, I feel this way. And then you have moments as you get more experienced in your field where, you realize, oh, I have no idea, what I'm doing here or what I'm talking about. And you really are just trying to do the best you can for, whatever the situation is in front of you. And I think it's a really important topic to talk about, because I think when you're a student, it's very easy to feel overwhelmed and to not understand that what you're going through is completely normal, especially in a world where there's so much to know that none of us are ever going to know it all. And I think Dr. Anderson spoke beautifully to this about how we really do rely on this network of people to support us. And I think that is one of the best parts about our field in genetics, is that we really can say, I have no idea. I've never seen a patient with this condition. I am so out of my depth right here. Let me reach out to this colleague who does this all the time. And as you get further along, you realize that that's kind of just part of the learning curve, is becoming comfortable with what you don't know. And I often tell patients, like, if I'm not the right person to answer this question, I'll tell you I don't know, and I'll try to find someone who does. And I think when you kind of start to realize that part of learning is just accepting that we are all learners for a lifetime, I think you start to become a little more comfortable with that idea.
Mhm. Katie behind the cat. Any
Yes,
comment?
please excuse me. My cat will ignore me for 2 weeks, but once I get on a Zoom meeting, then she must be in my space. That's an everyday thing, imposter syndrome, especially being the only person at my hospital who does my job, a very young early career person, and young early career in genetics every day is imposter syndrome. And it's a lot of asking questions. And I agree with Dr. Kritzer. When I don't know something, I do my best not to guess, because in a complicated field like genetics, although all of medicine is this way, guessing is rarely helpful. Sometimes when you're doing something that literally nobody else knows, it's okay to guess. But if there's a friend out there in the universe who might know the answer, you ask them.
Okay, Dr. Scott, your thoughts?
Yes, imposter syndrome, I think definitely we all have it, especially when you start off in Drosophila and you're on a panel with amazing doctors. So everybody feels it, and I think it's important to just acknowledge that all of us feel it, and to try and understand where it comes from, and that you just reach out. And I agree with everyone. Don't pretend that you know what you know. Google is amazing, and reach out for help, but just realize that we all struggle with it, and it's completely normal.
And what I would add to that is, if I encountered a young professional who did not have imposter syndrome, I would be worried about that person. I would have real concerns about that person. So if you're feeling it, that's right. That's good. So I think at this point, we only have a few minutes left. So what I'd like to do is to share, for those of you who are interested in thinking about genetics, here are some opportunities that you might want to consider. And you will be getting copies of this sent to you, so you don't have to write anything down now. So if you're interested in continuing this dialogue and finding out more how genetics might be a choice for you, there is the option of one-on-one conversations with a geneticist. And this could be a general clinical geneticist, a biochemical one, research or industry. We do have connections to link you to one of those professionals. It's an opportunity to talk about their careers, but also your interests. And so if you have specific questions about your own path, this is a good option. We just ask that you prepare a letter of intent and a CV, so we can pass that on to the geneticist, and he or she can review that in advance of your conversation. There is also the option of on-site electives, which is an opportunity to shadow a geneticist as she or he sees patients in clinic. You get to hear about the patient and the disease and the concerning issues of the day, but it does require advanced planning. because hospital clearance, security clearance is required. Again, just let us know and we can put you in touch with someone and prepare a letter of intent with the CB. So if an on-site, an elective in person in a hospital is where you go from room to room in clinic to see patients, then there is an online counterpart to the in-hospital experience where you are shown 3 patients and a clinician will tell you about that patient or their disease. But there is a real patient participation, usually as a video. And that replicates the situation. These are about 60 to 70 minutes in length, and they have a particular theme like causes of stroke or causes of encephalopathy. If you're interested, please let us know. Rare New England hosts the Rare Disease Day Speaker Series every year between January and March in honor of Rare Disease Day, which is the last day in February. And during that period, RNE goes to medical venues around the region with a physician who provides an overview of the disease of the day, and a patient or family member of a patient with that disease then talks about their journey with that disorder. These are 1-hour presentations, and there's a Q&A that follows. If you are interested, we can let you know where these are. They are, in general, hybrid events since COVID. So there will be an online way of attending. So if you're interested in watching, again, please let us know. And this is actually our Rare Disease Day Speaker Series from earlier this year. So we were at 11 venues around the region and saw a host of genetic and metabolic disorders, all rare. And then there is the American College of Medical Genetics Summer Scholars Program. This is a funded 6 weeks elective experience for medical students beyond their first year at selected academic institutions around the country. Now, they changed their timelines so that applications are actually due this Friday. And you have to, this has to be through an institution that participates in this program. If you go to this website, you will find out those institutions, and if they haven't chosen someone, then you might be a candidate. And then finally, the Global Genes Rare Compassion Program. Applicants, which are generally medical students, are matched with 4 rare disease patients and families, 1 every 2 months for a total of 8 months. Pairings are announced in March, and the application process for 2022 is closed, but 2023 is on the horizon. If you want to get notified when the Compassion Program opens, write to that email. And matched applicants, after their participation in the program, are eligible to submit an essay about their experience to qualify for one of 3 scholarships. And there's the website. So that's it for tonight. And I want to thank our speakers for sharing some of their passion with us. It's all very exciting and it's all very personal and very human. But thank you, and we wish you good luck. And attendees, thank you for joining us this evening. And please stay in touch and reach out if you would like to continue this dialogue about the possibility of a genetics career. Good night.